So hello everyone. Good afternoon, ladies and gentlemen. So welcome to this session titled How to Optimize TAVI Outcomes in APAC Population. That is quite a relevant topic to our APAC people. I'm Kentaro Hayashida from Tokyo, Japan, interventional cardiologist. I would like to co-chair this session with Dr. Didier Cheche from France. And today we have a lot of the very experienced discussants like Dr. Michael Lee from Hong Kong, Dr. Shara Shetty from Australia. We also have the Dr. Marisa Taramano from Switzerland and Dr. Stefan Rothley from Australia. And the learning objectives of these sessions are to understand how to optimize the clinical outcomes for a TAVI patient with small annuli. Because our Asian cohort has a lot of patients with small annuli, it's quite relevant to our daily practice. And to learn how to mitigate the risk of the conduction disturbance after TAVI, that is also quite important topic in our daily practice. And to discuss how to optimize lifetime management for TAVI patients. Now the indication is shifting towards much younger patients, so it's quite important to topic. So let's discuss together. So maybe, yeah?
Yeah, and you still have the option to be part of the session by using the app and sending us your questions, and we will try to address them. We will address them during the flow of this session. So, as usual, we try to remain as integrative and interactive as we can, so feel free to come up with anything you have in mind. Okay. So the first speaker is going to be Masanori Yamamoto. Masa, who's going to drive us through how to optimize the TAVI outcomes in patients with small aortic annulus.
Yeah, thank you. Okay, thank you very much for everyone. And it's a pleasure to be here, and I would like to present Here is my disclosure. So here is a history of TAVI in Japan. So before introducing the TAVI devices in 2013 October, a young Japanese fellow learned the procedure of TAVI in Europe, in France or Italy. And Kentaro and Yohei looks young, and I'm still young. Okay. And also,
still young.
Yeah. Okay. So, okay. There are many new devices are coming, and the clinical consideration is focusing on the valve performances between the valves. So the bioprosthetic valve dysfunction, for example, everybody knows the results of the SMART trial, the incidence of the bioprosthetic valve dysfunction is significantly lower in the self-expandable valve comparing with the balloon expandable valve. But the data and the valve is a little bit older one, so we need to adjust the latest generation devices. In addition, considering the balance between the annular size and body size is so important, the valve performance is maximized. For example, the small annulus but small body surface is, I think that any kind of bioprocess is welcomed. And also in such kind of Asian Pacific, but in Japan and West Australian populations, the body surface areas significantly differed between the groups. So that the target is a small annulus but large body surface area, such kind of population. Probably we physicians consider the self-expand valve is better for such kind of patients. Okay. And what about the clinical impact of severe PPM in our ocean registry data? First of all, because of the small body surface area, the rates of the severe PPM is extremely low, 1.3% in our cohort. Even we collected the 7,000 patients, 1.3. But the clinical impact of severe PPM, existence of severe PPM is associated with the increased risk of the mortality comparing with the moderate PPM or no PPM. So if possible, we need to avoid the severe PPM in our cohort, in our small body surface area cohort. Okay, that is a start line. So we need to compare the latest generation THVs for small annuli. For example, the latest generation Sapien 3 Ultra Resilient valve showing the better hemodynamics and comparing with the previous Sapien 3 valve, And we have also evaluated effects of navitor valve, intra-annular or supra-annular self-expand valves. Here is focusing on the small anatomy and small annulus in Japanese populations. After propensity matching analysis showing there is no significant difference between the rates of the severe PPM, but the incidence of the mean pressure gradient more than 20 is significantly higher in the latest generation balloon expander valve comparing with the latest generation supraannular self-expander valve. In contrast, the rates of the PVL more than mild, equal or more than mild, is significantly higher in the self-expander valve. As a result, the back-defined device success are completely same between the groups. What about the Sapien 3 Ultra Resia versus Navitor valve? So here the left side upper panel showing the overall cohort, and lower side is a propensity matching cohort, and the right panel showing the focusing on the small anatomy. So the results are completely same between the balloon expandable versus supraannular self-expander valve. The completely same. Higher rates of the mean pressure gradient in balloon expander valve is maintained, but the rates of the PVL is lower in the balloon expander valve, and incidence of the PPM is significantly higher in the balloon expander valve comparing with the intra-annular self-expander valve. And the last question is very interesting. Which is better, intra-annular versus supraannular self-expander valve? I compare using the data of Ocean Registry, and after propensity matching analysis, the data showing with statistical significance, the mean pressure gradient 8.7 versus 7.8 between the supraannular and intra-annular self-expander valve with statistical differences. But the actual value of the mean pressure gradient is 0.9. I think it's marginal. Okay, and let's move on the incidence of severe PPM. In the matching cohort, there is no significant differences between the group in terms of the severe PPM. In contrast, the rates of the PVL is a little bit lower in the intra-annular self-expander valve comparing with the supraannular self-expander valve. Okay. And we focus on the very specific small THV size. For example, comparing with the balloon expandable valve versus intra-annular self-expandable valve. And the target range of the area, we need to consider the Navitor 23, intra-annular self-expander 23 is truly covered in the range of the Sapien 3 Ultra Resia 20 mm, not 23. So that we need to compare the results between the 20 versus 23. Okay, so if we focus on the balloon expandable valve and the intra-annular self-expandable valve, rates of PVL is similar. And the rates of the mean pressure gradient more than 20 is lower, and the rates of the PPM is lower in the intra-annular self-expandable valve. And move on the focusing in the intra-annular versus supraannular self-expandable valve. And I did the propensity matching analysis using adjusting in the perimeter, same size perimeter, and deploy the 23 mm valve. The results are showing, interestingly, intra-annular self-expandable valve is a better hemodynamics. And the number of the cases is only 60, so if we include more patients, I think there is a significant difference between the groups. So the conclusion of the updated using the latest newer generation devices, the results, the patient with small annuli is here. But these results everybody knows that 10 years ago, the results never changed at this moment, okay? And what should we do next? We need to reduce the rates of PVL and rates of PMI if we choose a self-expandable valve. But Dr. Yohei Ono will nicely present how to reduce the rates of the PMI. So I would like to mention about a little bit how to reduce or how to consider the higher rates of the PVL in our cohort. Because let's go back to the SMART trial results. Surprisingly, for me, it's very surprising because the rate of the PVL is similar between the two groups in the RCT. In contrast, even after propensity matching analysis in our ocean registry cohort, the rate of the mild PVL is significantly lower in the balloon expandable valve comparing the self-expandable valve. But I considered our data didn't include the calcium volume or calcium score, such kind of a huge calcification existence. We didn't enter such variables into the matching analysis. Okay, so this is my first case of NAVITA, huge calcification. Such a patient, we prefer to choose a self-expandable valve. So I think I may be consider the rates of the PVL differences a little bit overestimated in our daily practice. Okay, so here this is a summary. And take-home message is in patient with small annuli, using the latest generation THVs offers different clinical results depending on the specific device characteristics. And conclusion is better hemodynamics in self-expandable valve, but relatively higher rates of PVL and PMI. And considering acute phase outcomes may help optimize device selection. However, these early differences impact long-term prognosis remains an open question for future researches. Thank you. Thank you for your kind attention.
So thank you very much, Masa. This was a very interesting talk. And it's always a surprise to me because coming from a Western country, we see slightly different findings. And it's, so if I understood you correctly, if you use compare self-expanding platforms in small aortic annuli, this intra-annular platform may achieve better hemodynamics than a supra-annular. What do you think is the main reason? Does it have something to do with the shape of the stent frame, the way the leaflets expand?
Thank you very much. It's depending on the shape of the structure of the bioprocesses, I think. Because, for example, the supraannular self-expand valve, if we choose a 23 millimeter devices, the distal part is a 23, but the waist is 20. But NAVITA valve is a cylinder type, so that means, so for example, the 29.5 millimeter annulus area, but the upper side also maintaining the 21.5. But if we choose the self-expand valve supraannular evolute, we choose a 23, but the proximal part is 20. So that is the reason why the better hemodynamics, especially in the patient with 23 millimeter bioprocesses, better hemodynamics in the intra-annular self-expand valve, I think.
Okay, so potentially the location of the leaflets and the more tubular configuration plays a role. So maybe Michael, I can ask you one thing. If we think a patient who is in a gray zone, a patient is a gray zone between two valve sizes. If I want to use a self-expanding supraannular platform, most of the time, if the sinuses are large enough, I would use the larger valve size. Mm-hmm. With the Navitor and Navitor Vision platform, given the hemodynamics that Masa has just demonstrated, would you still apply the same philosophy, the same concept, or would you stick to a more one-to-one ratio, assuming that the valve is going to be large enough? Yeah, what would you propose?
I think with the latest Navitor Vision, we can actually, as you mentioned, not really need to oversize too much. We aim at one-to-one usually. So if it is like in between, that depends on how much it is actually towards the other end. So if it is just a little over, like a little over 26, we can use a 26. But if it's near a 29, then we can actually choose a 29. So that's how we chose our valves nowadays. Don't need to be too much oversized.
So in comparison to you guys from Australia, so different patient population. Well, for us, you are considered in the same region of the globe. So, so what is your experience there with this platform, intra-annular platform in small aortic annuli? If you ever experienced this type of configuration.
Yeah, look, you're spot on. We tend to have a little more Western population in Australia, even though we are part of Asia Pacific. But but our experience is exactly as has been presented, which is that the hemodynamics are excellent. We definitely in smaller annuli will prefer to use these sorts of valves because basically as we're seeing published, we're still getting mean gradients that are single digit. And I do think it's the design. The thing that I think that's helped us understand is in the past there was this narrative of supra-annular versus intra-annular, but actually it's not true. It's actually all about its stent frame and valve leaflet design. They're the key two determinants. And so the unique features of Navitor has led to the fantastic hemodynamic results that we saw presented.
And Mauricio, having seen the result, do you think that we know the outcomes coming out from SMART? SMART has been discussed a lot of time, and we understand that there is a difference in terms of hemodynamics between a balloon intra-annular expandable platform and a self-expanding supra-annular. Do you think that there is a need for a head-to-head comparison of the intra-annular self-expanding and supra-annular in small aortic anatomies, just to better understand if there is a device of choice, or are you happy with the results out there?
Of course, I think this comparison will be done. To be honest, I think the data that we have so far are probably enough to say that intra-annular self-expandable platform is probably performing better than a balloon expandable intra-annular. So do we really need a head-to-head comparison to confirm that? This is the question. I think we will do it because we need to prove it, but if you think of the way how the leaflet of Navitor, for example, open, so they completely go against the stent frame. This is just because they are mounted in a different way, while the leaflet of Sapien, for example, at the moment, they don't open all the way. So this will be in the next generation change, but it has to be done really with the leaflet designers.
I have one question for you, Massa. It may be a kind of challenging question, but we talk about design, tubular configuration of the stent frame, the way the leaflets are sutured, they expand. But it's all about the landing zone. And in the tricuspid anatomy, we have to integrate the LVOT. So if the LVOT is really tapered, are you considering a different height? Because if you go a little bit too deep, there you may experience too much compression of the stent frame, and then the hemodynamics can be impaired and impacted. Yeah. Is it something that you integrate?
Yeah. We consider, of course, as you mentioned, but this is our learning stage of the Navitor valve intra-annular, so that's a little bit, we need to try to very, very fine positioning, but risk-benefit balance between the tilting or embolization or something. Sure.
Sorry, I just had a quick point about your reference to the body surface area in our populations, and as Massa's presentation demonstrated that you could have a small patient and a small annulus, and which is probably more in the Japanese quad. We're probably more likely to have larger patients with small annuli, and it's all the more important to have a more effective, larger effective orifice area in our patients, I think. I think you indicated the body surface area was 1.44. I'm not sure what the Australian one is in small annuli patients, but the average body surface area is about 1.9, not in these patients, of course.
Thank you very much, Massa.
So we have a very good discussion. So I'd like to invite the next speaker, Dr. Yohei Ono from Tokyo University Hospital, my girlfriend, and he's going to talk about how to achieve low pacemaker implantation rates with the latest intra-annular self-expanding device.
Thank you, Kentaro. Following Massa's very academic and exceptional talk, I would like to tackle another important topic, how to reduce the pacemaker rate using this platform. So as we expand our indication to the lower risk patients, it means a little bit younger patients with longer life expectancy. We need to consider several things to how we can optimize the outcome of index procedure. Masa has nicely mentioned about the hemodynamics of the procedure, which will eventually translate to the better durability of the valve. Now, for the sake of time, I would like to focus on how to reduce pacemaker implantation after the valve implantation. Well, as you may know, there's still relatively high pacemaker implanted rate reported in previous literature. For the Navitor ID clinical trial, it's reported to have 19% of pacemaker rate. I had a chance to chair this morning about the TAVI outcome session, and there was 3 Navitor outcome study, and all reported around 16 to 8% for the current contemporary practice. So still some room for improvement. Our Ocean TAVI registry reported 9.7%, slightly lower than the other study. And it clearly shows that there's a learning curve in this device, that from the early experience to the late experience, although it's not statistically significant, there's an improvement in the numbers. So obviously there are lots of rationale behind this, how we should reduce the pacemaker implantation rate, a lot of costs, risk of infection, and so on. And there's a negative impact, as you know, with persistent left bundle branch block or RV pacing. One of the concepts is established as abnormal conduction-induced cardiomyopathy. And if you use a lead pacemaker, it would eventually be a cause of lead-induced TR. And now this meta-analysis have shown that there is association with a hard endpoint like cardiac death or all-cause death, heart failure hospitalization with pacemaker implantation. There are several established risks of pacemaker implantation, such as baseline conduction abnormalities, right bundle branch block. Now we mainly focus on how long is the membranous septum, based on the pre-TAVI CT scan. As for implanter perspective, we can try to refine the implantation depth for each patient, and oversize of the valve matters as well. So we definitely need to understand the anatomy of the conduction system, which usually lies down between the right and non-coronary cusps. And there is a variation from patient to patient. We often see with a CT scan assessment. As you can see here, there's a membranous septum just below the aortic cusp, and then there's a muscular septum which left bundle comes up to the surface of the left ventricle. So the idea is to implant the valve within this range. And there's always a trade-off when we decide the implantation depth for each patient. If you want to avoid pacemaker, better to stay high. However, when we consider the coronary access or the future redo TAVI, maybe we need to not to go too shallow for this perspective. So there are several tips and tricks how to reduce pacemaker implantation. Obviously, the implantation depth matters really well. And we know that, as I mentioned already, the depth of the implantation device has to be shallower than the length of the membranous septum. Imaging can help assist in this setting. We've been studying a lot for this, and I think visualization of the membranous septum during the procedure with intracardiac echo helps this as well. An appropriate use of recapturing, since we have a recapturing system for Navitor platform, helps if we go too deep for the first implant and a conduction disturbance happens, we may recaptures go slightly high and we can restore the conduction. The conduction system is very dynamic, as you may know. Optimizing size also matters, respecting the patient's baseline anatomy. And obviously, we need to follow the best practice, what is recommended. So I would like to show a representative case, 85-year-old female, symptomatic severe AS, elevated natriuretic peptide levels. CT scan showed no significant coronary stenosis. Echocardiogram showed very severe high-grade AS. As for this specific patient, has small annuli, perimeter of 67.8, perimeter-derived diameter is 21.6. Sinus of Valsalva, this is frequently observed in Japanese patients, relatively small. So the valve choice, the sizing would be very important. ST junction is somewhat calcified with a diameter of 22.6. Coronary heights are okay, I would say, 12.2 for the left, 13 for the right. And this patient had a very bad hostile peripheral arteries, minimum lumen diameters, both 3 and 4 for the left and right. Membranous septum was measured as 3.8 for this specific patient. So as for the strategy, since the patient has limited size of sinus of Valsalva, just by looking at the perimeter, it's around 66, 67, so we can consider 25, but however, the sinus of Valsalva is limited to around 25. With this bulky calcium, if you implant 25, it could be a risk of coronary obstruction. So our plan was to dilate with good size of a balloon, 22 millimeters, is just around the perimeter base diameter, and then try to implant 23 for this specific case. As for the navigator derivative system, 14 French, nicely coated, hydrophilic coating. So even with this kind of anatomy, peripheral artery, without no significant calcification, we can quite easily go with this system. Good predilatation with a 22 millimeter balloon. And then, as we are fortunate to have navigator vision with 3 markers, we try to align the valve to achieve a commissural alignment in the descending aorta. So this initial attempt, we aimed to implant like 3 and 4 millimeter in the NCC side using the cusp overlap view. However, at the final phase, the valve slightly went deep into the left ventricle. Although there was no new onset conduction disturbance at this stage, we tried to recapture. And this was the second attempt. As you know, if we align the annular level at the top of the marker, it means the depth is more likely to be 4.5. If we align the annular plane at the bottom of the marker, it's more or less 3 millimeters. So it is very useful that how deep we are in each cases. And another important thing is to avoid underexpansion of the valve. It's called non-uniform expansion. One of the best good way to observe this phenomenon is to go to RAO, either cranial or caudal, to see the separation of each struts of this valve. If there is let's say 3, 4 struts in a very limited distance, it means there's a underexpansion of the valve that may require additional predilatation before the valve implantation. So there was no underexpansion, no significant non-uniform expansion was observed in this case, so we implanted the valve. But still we needed post-dilatation, and this was the final angio with 23 millimeter valve, slightly undersizing, but really good result for this valve. No additional conduction disturbance was observed after the procedure. Hemodynamics from mean pressure gradient 81 to 6 single digit. Post-procedure echo showed no AR, no signs of PPM. So still a limited and initial experience from our centers, but majority of the patients were female. BSA, as Masa mentioned, 1.4, small body size. Most of the cases were guided under ICE guidance. Majority of the size of the size selection was 23 to 25. Most of the cases went pre-dilatation, and around half went post-dilatation. So within this series, due to transient complete AV block, we went to the ward. 5 cases with temporary pacer. Among them, finally, eventually, one case required pacemaker. As for the incidence of left bundle branch block, still remains relatively high with 21%. So this needs to be some improvement over the future. Implantation depth remains around 4 millimeters of the series, and the current pacemaker rate is around 2%. So if the membranous septum is, let's say, like 3 millimeters, if we want to avoid pacemaker, we need to stay on the 3 millimeter. But there's some anatomy that allows or favors this kind of relatively shallow implantation, or better to stay on the safer side. So there are several aspects that we need to take a look at it, and the degree of calcification of the leaflets, how the ST junction is narrow, wide, or is calcified or not. Ascending aorta size matters, coaxiality of the valve. So these kind of things all need to take into consideration. So once again, to review the best practice, I think good predilatation is mandatory if the anatomy allows. Try to implant the valve within the membranous septum and confirm there is no significant underexpansion or the non-uniform expansion before the final release. And as for the coaxiality is also important. For instance, the left upper panel, we have a good position of the shaft, delivery shaft in the middle of the ascending aorta, whereas the lower panel shows the shaft is towards the greater curve. So it means after the final release, it may tilt towards the inner curve. So there may be some movement over after the final release. Navitor ID trial showed some of the important features that may associate with a new conduction disturbance. So as for the summary, this newest platform, Navitor Vision, makes assessment of the depth control as well as the commissural alignment much easier. And we would like to try to implant the valve within the membranous septum. And in order to achieve that position, good predilatation, good preparation with implantation under cusp overlap is mandatory. Thank you for your attention.
Thank you very much, Yohei, for a fantastic lecture always. And I would like to congratulate on your great result with the 1.8% of the pacemaker implantation rate. It's quite amazing. So nowadays we have the Navitor Vision equipped with the very big marker, 3 millimeter and 4.5 millimeter. How do you utilize this marker to optimize the implantation depth?
Thank you, Kentaro. So as I mentioned, we tried to analyze the membranous septum length with a pre-procedure CT scan and tried to implant the depth at the NCC side using the cusp overlap view, try to stay within that length if possible. So
within means less than 4.5.
Yes, less than the measured membranous septum using that marker.
Okay.
Yes.
And if the measured membranous septum length was 2 millimeter or something, what would happen?
Great question, and sometimes we appreciate this kind of anatomy based on the CT scan, but I would not risk it to go even shallower. So basically, most of the cases I try to implant not shallower than 3 millimeters. So if that's the case, my first attempt would be 3 millimeters, and we even with the CT scan shows that kind of short membranous septums, due to the variation of the anatomy of the membranous or the conduction, we may have or we may not have the conduction disturbance. So my first try would be the 3.
Maybe the ICE measurement is a little bit different from that of CT measurements.
Exactly.
Thank you
That's
so
right.
much. So any questions or how? I think that the avoiding the non-uniform expansion is quite important, and you had nicely commented on the very good predilatation. So Michael, could you please tell us what is your tips and tricks to optimize the predilatation and how to avoid the non-uniform expansion? Tell your experience.
Yeah, I think it depends very much on the anatomy. If it is a very calcified annulus, then you have to have adequate predilatation. I think it works in all valves. And then when we load the valve and we are going up, as Yohei has mentioned, we should look at the parallel position of the 3 dots so that we know it's actually properly loaded. And then with the different views to look at the non-uniform expansion. And then at the end, if it is really, you think it's inadequate expansion, I will have no hesitation to post-dilate the valve, try to obtain optimal results.
Yeah. Which balloon would you choose for predilatation?
We use, for predilatation, usually we use a semi-compliant balloon, the nucleus or the CMAC. But for post-dilatation balloon, we always use a true balloon.
True balloon.
We have the true balloon available in Hong Kong.
Okay.
Yeah.
What is your thought, Jared?
I'm actually glad that the company is now recommending going up to perimeter-derived area for predilatation. I always felt that a good predilatation would make it, and we only started it off late, and I do think it's much better. It allows for more uniform expansion. And with regards to the other points, I think I echo the thoughts of Michael, and pretty much try and aim for. We don't routinely look for length of membranous septum. Maybe perhaps we should, but in the past we used to go a bit higher than 3, but now we try and stick to between 3 and 4.5 if possible.
Yeah, great. So Mauricio, you also have huge experience. So could you please tell us how do you avoid non-uniform expansion for navigator?
Yeah, I think the first point is to recognize it, because sometimes you don't pay attention too much, and then you release the valve, and the valve can eventually also migrate. So this is probably the most frequent case of aortic migration. So it's really important to recognize, so to go RAO, as Ono said, to really be sure that, especially if you have a highly calcific anatomy where you somehow can expect this complication. It's not a complication, but that you can expect that it happens. And if this happens, of course, I think you have 2 options. One is probably, or 3 options, is start, as you described, recapture and start the deployment slightly more towards the LVOT, so more far from the calcification, and then open maybe a bit slower, so to give the nitinol the time to open a bit more, and then go back once the stent flare nicely, go back to the landing zone. We don't know if you may eventually scratch a bit the LVOT and eventually increase the risk. This we don't know, but of course you can overcome this issue. Or you can eventually remove the valve and do a more aggressive predilatation. This is eventually also something that can be done.
Yeah. So actually, our previous fellow, Yusuke Kobaru, demonstrated the distal opening technique inside of the left ventricle. But if you do too much, you might take a risk of the injury of the conduction disturbance. So we should be careful. So Didier, please tell your experience.
Yeah, no, I have to say that I love the distal opening technique coming from you guys. And I understand that we may use the markers to just tailor the final depth, being on top of the markers, below the marker, below the distal, the inflow edge of the marker, or just in the middle. It's going to help us vary within a 1 millimeter range. We accept that. But there is one thing that I like from your comment, Maurizio, is about the speed. The slower you go, the better it's going to be, the more control you're going to get for the inflow. But Joey, do you also apply that type of technique for the outflow? Because one thing is to get the proper depth of implant, another thing is to keep it during the final release. And what would you recommend for the expansion of the outflow?
Well, a very important question, comment, Didier, thank you. So first, during the expansion of the valve, I personally like to use the pacing. So I'll start with like control pacing 100, and just before the frame reaches like a left to right cusp with the cusp overlap, I increase the pacing rate to 140 to make more stabilization of the valve to expand. And after that expansion, I will carefully observe how it's expanded in various fluoro views. And I think because of the nature of the self-expandable platform, we need to give some time for the device to expand. So while assessing with the echo, transthoracic echo, and so on, checking the conduction system, we give time for the valve to expand. And then within several minutes, we make a final decision whether we should go for the final release or do a recapture. Yes.
And one thing, Johan Nasser demonstrated the case with calcified ST junction, that is really good sign, so you don't need to take any risk for the embolization with navigator. The patient selection is also quite important.
That's right.
Okay, very good discussion. So thank you very much for your nice presentation.
So the last talk is going to be provided by Michael Lee about how to select the optimal index valve for patient lifetime management. So this is a very ambitious menu, so thank you.
Yeah, thank you, Didier. As you mentioned, lifetime management can be a whole day's talk, but I'm just going to concentrate on some of the elements. So when we look at the expansion of TAVI to intermediate, lower risk patients, younger patients, we see a very gradual increase in the number of TAVI procedures being performed, while we see a decline in the surgical aortic valve replacement. And the trend, I think, is more prominent in this US national trend in TAVR and SAVR, that the younger patients, less than 80 or even less than 65, you see there's actually a sharper increase in the number of TAVI procedures being performed. So now we are facing a group of younger, lower risk patients. And then we have to talk about this lifetime management for these younger, lower risk patients. So these are the elements that we should pay attention to that Yuhei has just mentioned as well. But today I'm just concentrating on the future coronary access and probably TAV in TAV at the end. So now we are all practicing minimalist TAVI procedure. When we are considering young patients, this is especially important. It should be a much simpler procedure than before. Local anesthesia, no TEE or echo anymore, no central line. We always use LV pacing, so we don't put in temporary pacing anymore. Both femoral puncture or one femoral plus one radial. And then the patients would usually be mobilized early, within 4 hours, and then probably discharged the next day. So this minimalist approach is, again, getting more and more important when we are facing younger and lower risk patients. These are the available devices available in Hong Kong. We are using all of these devices, but when we are facing a younger, lower risk patients, there are some devices which we should pay more attention to in order to achieve a better result in the future for these young patients. So we all know coronary artery disease actually usually goes hand in hand with aortic stenosis. About 40 to 80% of severe aortic stenosis patients actually are having various types of coronary artery disease. And a lot of these patients will need PCI angioplasty after the TAVI procedure as we move to lower risk and younger patients. And if you look at the Sweetheart registry, you will see that in the next 10 years, for those patients younger than 70 years old, they will have about 1/3 chance, 30% chance that they will undergo angioplasty in their lifetime in 10 years' time. So coronary reaccess is very, very important as we move to younger and lower risk patients. The benefit of this Navitor Vision is twofold, I would say, in terms of coronary reaccess. First of all, it's the large cell design. You can see this very, very large cell so that we can actually cannulate the coronary arteries pretty easily. And then the intra-annular design would produce the lowest neo skirt height that among other self-expanding devices. If we look at the leaflet length and the neo skirt height, you will see that, of course, the balloon expandable shorter frame device will have the shortest neo skirt, so that will obstruct the coronary reaccess in the future. But if you look at the taller frame self-expanding devices, you will see that the smallest neo skirt height is actually achieved with Portico as well as the Navitor, so that this shorter neo skirt height will actually allow easier coronary access in the future. And in fact, when we look at this caveat registry, we can see that, again, balloon expandable shorter frame device would actually allow us to have easier access to the coronary arteries. But if you look at the tall frame self-expanding devices, you can see that Portico Navitor actually is much easier to be re-engaged both the left and right coronary artery as compared to some other self-expanding devices, especially for those supra-annular devices. But of course, this registry is comparing Navitor or Portico with the Absolute Pro or Pro Plus. It's not really the FX Plus that we are comparing. And the other aspect is the commissural alignment. We know that when we want to have easier coronary access, we try to align the commissure properly. So try to move the commissure away from the left and right coronary artery. So we usually will do this in the cupped overlap view. So we just keep one commissure post to the right of us or to the patient's left side, so that this will enable the right and left coronary arteries being free from this commissure post. There are also evidence that even if we don't do commissure alignment, random Nevertore alignment, presented by this e-poster last year in EuroPCR, well, actually, we still can access the left and the right coronary artery selectively in more than half or 70% of these patients. And the other possibility would be the non-selective means to access this coronary artery. So even if we don't do commissure alignment, Nevertore probably would be the easiest to engage the coronary artery. And then finally, when we talk about younger patients, we have to talk about what the TAV procedure, because these patients, TAVI device is going to degenerate, it's going to fail in the long run, so we have to put in another device. By then, coronary reaccess is again very, very important. This just published a CT-based analysis of when you redo TAVI, what are the possibility that their coronary arteries are being occluded. You can see that if we implant the Nevertore at our standard height, 3 to 5 millimeter, not too high, and or lower, there is actually a pretty good chance that we won't actually occlude the coronary artery. More than 50% chance that we won't. If we implant the second valve, a balloon expandable valve, high. But usually we will aim that second valve to be lower. So if we implant the second valve, S3 valve lower, then you will see that with the Nevertore, no matter which position it was put in the first procedure, then the risk of coronary occlusion is actually very, very minimal. If we compare the different tall frame self-expanding devices, you can see that if we implant the S3 Edwards valve high, then the easiest or to re-engage or the least chance that the coronary arteries will get occluded will be the Nevertore valve. And then even if we implant low, even the rate is lower, but we still will get a much lower rate with the Nevertore device. That means if we want to have less coronary obstruction, better later coronary reaccess, we should implant the Nevertore at the suggested optimal height. It would actually give a better result as compared with the other self-expanding valves if we put in a second valve with this balloon expandable device. And in the Asia-Pacific forefront, we also published our own consensus statement about this lifetime management. So for us, we think that for patients less than 65 years of age, we still would recommend surgical AVR, but probably bioprosthesis first and then consider future TAVI procedure. But for all those patients older than 65, and then we probably should discuss with them, we should go for TAVI first and then redo TAVI in the future. So if we consider this redo TAVI or even redo TAVI, then the first valve is very important. Optimal position of the first valve and then the optimal selection of the most appropriate valve is the most important for this patient's lifetime management. So there are a lot others to consider. But today, I'm just highlighting to you future coronary access and the future TAV might be one of the most important factors to consider when we choose the first valve for these younger and lower risk patients. Thank you for your attention.
Thank you very much, Michael. That was a terrific speech. There are a couple of considerations that are interesting to discuss, and if we come back to the CAVIT registry, it was kind of a surprise, even though the rate of re-engagement of the coronary arteries was higher with the Navitor and Portico platform, it wasn't still below the SAPIEN.
Yeah.
And do you think that it has something to do with the commissural alignment at that time, or How do you explain that?
Oh, I think because for a lower frame balloon expandable device, you don't really need to do commercial alignment. Although some people will do a commercial alignment for those as well, because it's less important. But for taller self-expanding valves, commercial alignment actually impacts a lot on the future coronary access. I think if we run another trial, try to aim at perfect commercial alignment, then the Navitor valve probably will have similar coronary reaccess rate as compared to the balloon expandable valve.
Yeah, I fully agree with you. And I have to say that I would like to congratulate the Abbott guys because by just putting these dots on the Navitor, it made our life much more easier. So honestly, now we can see what we are doing. We can tailor the depth. We can align the commissures. That's perfect. So that's great. But let me challenge you, and I would like to get a kind of discussion in between you guys. So you, if you're going to come here, and Masa, you can take the microphone over there. We have to, at the end of the day, we have to provide guidance to you guys in the audience. And we have had two talks. Yo, if I summarize, the higher you are, closer to 3-4 millimeters, the lower is going to be the pacemaker rate. And Mike, you're telling us, if you think about the lifetime management of the patient and you want to do a redo procedure, maybe it's better to bring the Navitor slightly lower. So how can we judge that? What is the final answer? Yoe, what do you think about it?
Well, great discussion, Didier. But I believe the index procedure should be highlighted more than the potential future redo TAVI, because you never know if the patient will need it or not. Of course, very low young patients could have higher chance of having a redo procedure. But I would like to focus on the index procedure because, as I mentioned, if we develop pacemaker, negative impact for the cardiac function in the long run, so on. So I would still focus on not going too aggressively shallow, because I learned from Michael's talk that some room for going slightly low can increase the chance of future coronary access. So, but still within the range of 3 or 5 would be my ideal for the index procedure.
What about you, Masa? Would you go towards the same direction?
Yeah, but
maximizing the index procedure?
No. Our Japanese cohort CT analysis clearly showing that if we implanted the valve as much as possible to high, so the sinus sequestration is double. So it's a very accurate to reduce the pacemaker implantations. It's a trade-off, of course, but I think that I totally agree with Yohei's opinion.
So this is a kind of very strong message coming from you guys. You say high, hello, Yoe, but not too high. Otherwise, we're going to impact the outcome. Mike?
Yeah, I think that is exactly why we designed Navitor Vision as it is nowadays. So we don't really need to put too high or too low. Of course, too low, you will jeopardize pacemaker rate. But we don't really need to put it too high, because you can see from the evidence, large cell design, intra-annular, very, very low new skirt height. Even we put in the perfect position, 3 to 5 mm, it won't actually jeopardize future coronary access as compared to the taller frame supra-annular design. For supra-annular valves, we really need to put lower to facilitate coronary access. Then we will be sacrificing pacemaker rate. But for this valve, I don't think we need to do that. We just put in the perfect position. First device and first procedure is very important. 3 to 5 mm would be my suggestion.
Thank you. And Sharad, we regularly talk about lifetime management of our patient, and we understand the importance of the index procedure just to keep the door open for a redo procedure. But sometimes we have to make trade-offs and to sacrifice some potential benefits. If you had to prioritize the main goals for a young, low-risk patient, you do a TAVI procedure thinking about a redo in the future, what is your main consideration that you take into account?
Look, I agree that one should never jeopardize the primary index procedure for the sake of a potential future procedure which may or may not be needed, and if needed, we don't know how things are going to be in 10 years' time. We might be excising leaflets or splitting them and be using dedicated devices. One question I did have was that since you measure membranous septum lengths, and if you have a young patient where you have the safety margin of having a long membranous septum, would you then err on the side of going lower, or not really?
Well, that's a good point, but it may impact the hemodynamics if we go significant low. So, the bottom line is we should stay in the I should aim like 4 or 5, but not too deep. Yeah.
And one final question to you, Maurizio, because you're a surgeon here. We've seen the sequence that has been proposed by Mike, and I didn't see any explant. So if we start, should we say that we should never start with a TAVI procedure if we think that the patient is going to require a surgery because it's too complex, or should we bring back that explant within the algorithm?
It's a good point. I think in principle, probably yes. If we think that the valve eventually should be in the future, if you already plan an explant, then probably it's better to go for surgery right away. I think explant is and will stay something that we will need because some valve, they get infected, they get thrombosed, they cannot just be treated by TAVI in TAVI. And so explant TAVI will remain, but I don't think there is room to be included in the lifetime management as something that you plan to do. Yeah.
So very clear message. So I'd like to conclude by saying that it's very easy to conclude because your talks were fantastic. So I learned that with a self-expanding intra-annular platform in a small aortic annulus setup, I can achieve exceptional hemodynamics, large EOS, and very low gradient. And this is extremely reassuring for our patients. I've learned that with a perfect implantation technique, we can keep the door open to the coronary arteries, and most importantly, we can decrease the pacemaker rate to a level that is exceptional EOA less than 2, and it's a challenge for myself. So next year, and I now better understand how to plan the future of the patient and how to integrate the lifetime management when it comes to the index procedure. So thank you everyone for your talk, and thank you for attending the session. Bye-bye.